You for joining us. Happy Thursday. So welcome to our very first report roundtable with Dr. Darcy here. Um, so thank you all for registering and thank you for bearing with all the emails that you've got recently. We're glad to sort of re-engage and get to know you all and have these meetings like this. So without further ado, first thing I want to do is reintroduce our customer support team. So my name is Claire Griffin. I'm the clinical integration specialist here at NeuroCatch. I monitor the support inbox, so any clinical questions that come into the support inbox, I can answer or I can pass along if they're not for me. And I also do all of our customer trainings. Also on this call, we have Shannon Cotnam, Ryan's executive assistant and many hat wearer, as Shannon does many, many, many things that I could spend the whole rest of this meeting talking about. And also on here, we have Christopher Geyer, who is our technical support lead. Christopher also monitors the customer support inbox, so anything technical that I definitely cannot figure out on a Windows computer, yes, Chris will do anything going on with your system as well. So that's our team. Christopher and I also monitor customer support drop-in hours. So those are Mondays at 9 a.m. Pacific and Fridays at 12 p.m. Pacific. So Christopher and I just sort of sit in there and you can pop in and pop out at any time during that hour. And we're there to answer clinical questions, so going over reports like we're going to do today. Device troubleshooting, anything under the umbrella of NeuroCatch, you can come in and ask us. So that's what those are for. And the links to join are in the customer portal. You can also email any of us to get those links as well. And then before we get started, just an important update. We also have our first monthly clinical newsletter that went out on November 3rd. So those will be the first Monday of each month. The next one will be coming out, I think, December 1st. Those will be some customer highlights, case study reports, publications, product updates, and links to events like this. So definitely stay tuned. And if you're not on those lists already, again, reach out to customer support and we can get you put on those lists. Oopsie. Okay, and I guess without further ado, we'll get started. So I want to introduce Ryan, for those of you who have not met him, our Chief Scientific Officer and co-founder. So, Ryan, I'll let you take the floor and unmute yourself.
Awesome. Thanks, Claire. I had Shannon a couple offices down yelling at me saying I was on mute. So I think we have how many cases do we have to review?
So I have 4 on the slide deck here, and time permitting, we have a few more.
Okay, perfect. So I think the goals and objectives are to look through some interesting cases that have come from NeuroCatches out in the field. So thank you everyone who contributed the cases. We always love getting cases back and seeing how the NeuroCatch is out and helping people and helping clinicians do amazing jobs. I think that the main goal is really around the kind of report interpretation for these cases, to talk through and walk through them and see what we see and just highlight different uses and functionalities of the NeuroCatch system. So
I also want to mention quickly, if anybody does have any questions at any point, please put up your hand. Feel free to ask. This is interactive, so we want you guys to be involved, okay?
Yep, absolutely. It's a complete learning experience. So absolutely feel free to unmute and jump in with questions or put them into the chat line or what have you. All right, Claire, should we jump into the first one?
Let's do it.
Okay, so in this slide, what we're looking at is for those who've spent a fair amount of time with NeuroCatch reports, on this slide is both the table and the radar plot for a particular patient. I'm just going to narrate kind of what my eyes see immediately, and then that'll be when I look at reports, kind of what I look for. So the first thing that comes up in the report as it is today would be the table. And usually, naturally, I'm noticing that on the right side of the table, there's a number of the measurements are out of range. As I think most NeuroCatcher users know, we kind of look at 3 main responses. So that's on the left side of this table. The auditory sensation is measured with the N100. So that's it actually, each of these has two measurements. So that's why there's six, 3 times 2. So we have both the amplitude and the latency. Then the basic attention is measured with the P300 at both the amplitude and the latency. And then cognitive processing is measured with the N400, again, because these are waveforms or peaks, both the amplitude and latency. In the middle, you can see the measured response. There's an interesting, important thing to notice here, which is that if the AI algorithm has identified the peaks, it will appear in this sort of, let's call it brown shading. And if we use peak select and override that, then it will turn to blue. So immediately when I scan this, I know that there's been no use of peak select. This was all AI detected peaks. And then I can look at the response and immediately find out if it's out of range, was it out of range being lower or higher just by comparing the result with the reference range. To be honest, I tend to not spend a ton of time on the table. I tend to go quickly to the radar plot because the radar plot gives me a quick visual of what to expect when I look at the waveforms. So looking at the radar plot in this case, just to orient those for radar plots, this is kind of our unique translation of event-related potentials into brain vital signs. The green shading is the normative range. That's plus or minus a 95 and 5% confidence interval from our normative database. So the green shading describes kind of normative cognitive activation across these three responses and their two measurements of amplitude and latency. Often, if I'm talking about this, I'll mention that when we've done studies in care homes where we've had individuals who are in the last stages of their life and have cognitive impairment, we will see this result basically shrink to the center. So a fast way to read the radar plot is really to see, has the result moved towards the center, or is it within the normative range? The dotted line would be the median. So that's, if you're thinking in vital signs like blood pressure, that's kind of like our equivalent of 120/80 is that dotted line hexagon. And if it moves out towards the outer edge of the radar plot, then the responses are getting faster and or larger. So what you can see in a glance, and that's why we really like our radar plots, is that this particular radar plot does not look typical. And it's moved out with we'd expect to see a large P300 amplitude, fast N100 latency. And then we're also seeing some low amplitude and slow latency in the N400. So with that in mind, I've always encouraged people that it's really great to go look at the physiology, the waveforms, because the waveforms really do tell you, these radar plots and tables reflect what you'll see in the waveforms. So we'll shift now, I think, to probably the N100 waveforms. Yeah, so a couple things just to orient. Just again, I don't want to assume that necessarily you've looked at a lot of these. So these are the physiological waveform data. The graph shows on the horizontal axis time in milliseconds, all the way out to 900 milliseconds, so roughly a second. And then it shows the response size, and also because these are electric potentials, the polarity on the horizontal axis. And positive is plotted up and negative is plotted down. And then the N100 is actually derived, if you're listening to the NeuroCatch, from the tones, the beep beep, where there's two types. There's a sort of a standard routine auditory tone, that's the standard tone in purple. And then there's a novel random deviant tone, which is in green. And so what you can see here, we expect kind of the reason scientifically we call it the N100 is we expect a negative peak prototypically around 100 milliseconds. So one of the things I like to guide people to do is actually look at the standard tone waveform because that has a lot of trials averaged into it. It's a very stable waveform, and you can usually see the N100 peak quite consistently. You see a negative deflection around 100 milliseconds. So the interesting observation here is I would probably have recommended using peak select to adjust the AI to the peak that's a little later. In this case, it was flagging, you'll recall, as being quick and early at 54 milliseconds. What that would mean is that the sound went from the ear to your sort of auditory sensory cortex in a very rapid time, half the time it normally does. So I would typically have used peak select to adjust that to that second peak that Claire has done a phenomenal job identifying on the slide. Thanks, Claire. So the lessons from this is just that the purple standard waveform is the most stable waveform, and that's one that you can check right away. And then we can move, actually, we can use the peak select tool, which I'm sure we can do tutorials on for those who haven't used it, to adjust this if the AI has not found the peak that the human brain is much better at necessarily discerning. So maybe we'll go to the P300 and basic attention now. All right. So what do I see here? Immediately, I see a very large P300. The radar plot indicated that, as did the table. We are seeing a P300. If you look at it's actually labeled at 13.64 microvolts. So I would generally describe anything between 10 and 20 microvolts as being a large P300. What does that mean? It typically tends to mean that we noticed that the P300 is very much, the amplitude of it is driven by arousal. So this could mean, often we see it clinically in individuals with PTSD or anxiety. Similarly, we've done some studies where we looked at changes before and after drinking Red Bull, and we actually saw the amplitude of this almost double in size. So I would generally look at something like this as indicative of a high arousal state. We can move now to the N400. So this is another interesting case. Again, we've switched now to when you hear the beeps, then shortly after that, you'll hear either matching or mismatching word pair primes. So something like bread butter or nurse doctor, or a mismatching word pair prime like nurse car. And so you can see that the mismatching words are in green and the matching words are in purple. What does my eye catch here? My eye catches that the pre-stimulus baseline, so that's minus 100 to 0, is relatively flat. So that's a quality check. I'm really looking actually for the positive peak at around 200 milliseconds in both waveforms. We call that kind of the P200, and that's kind of an attentional processing peak. It's very signature of a high quality cognitive processing N400 waveform. Of course, with it being called the N400, we're expecting a negative peak around 400 milliseconds. And there you can see that the AI has plotted a peak at 610 milliseconds, which is quite a distance off. Now, the N400 is probably the one that I do a lot of teaching on because what I'm seeing here is that there's a peak in the green line ahead of that it's probably going to be around 340, 350 milliseconds. I would use peak select in this case and actually adjust that peak to identify that earlier one. The reason for that is a larger driving down negativity that's earlier. And I think that actually indicates the N400 in its true time. I think that the second peak, the algorithm, scored just because it fit its parameters, but it's not an accurate peak. And in general, the algorithm is trained to do its best job to identify the N400. But just like automated driving, the human brain is always going to beat AI to the still. That may change in the near future, but and we're certainly developing the AI to be as strong as it can be. But in general, if you have a peak that is coming off the P200, that is a strong and clear defined peak like this one that we're looking at, then you would be okay to use peak select to move it. Okay. So that's scan one. Should we move to the next scan? All right, this is a great case. Thank you for the referral of this case. We get amazing cases. Oh, any tips on distinguishing between an early N4 and a PMN? Yeah, great question, and I'll jump right back into that. So a PMN, for those who are not necessarily aware, is related to what's called the phonological mismatch negativity. So it's the peak preceding the N400 that is sensitive to the unexpected sound of a mismatching word, whereas the N400 is actually sensitive to the mismatching semantic meaning. And so my tips around not everyone shows a PM in an N400 complex. You'll usually see it, you can see it as kind of like a small bump and then a bigger bump in terms of the peaks. The algorithm is trained to see the N400. So if it gets that, it will select for the N400 over the PMN. My tips are that the most important thing, particularly because NeuroCatch is used a lot in repeat scanning, is keep it an apples to apples comparison. So if you select, or the algorithm has selected the N400 and there's an earlier peak that's the PMN, don't mix the peaks. So if you get another record where it is in fact showing as a PMN and you mix those, that would be kind of a problem. So you always want to match to try, if you're going to adjust the record, to the best peak. There is a question from Andrew related to this of, is a second smaller later peak an echo or a reflection of the decision made? We do see, great question, Andrew. We do see that you can have the first peak come down, which I would flag as an N400, and then you can have, as somebody's continuing to do semantic processing, that can continue to drive the negativity down. So it would be correct to think of it as a reflection. I think to sort of put these two questions together a bit, what drives the waveform is you're hearing speech in time, and the first thing you hear is an unexpected sound, and then you convert quickly that leads on to an unexpected meaning. And if you continue processing the meaning, then the waveform will continue to drive negatively, like you see kind of in this case. What you want to do is give the individual, if you're going to override and use peak select, you want to give the individual the most accurate driving early negative peak that represents where you can see that it was driven down for semantic access, detecting a mismatching word. It's like scoring a test. You wouldn't want to inadvertently score someone slower and give them slower cognitive processing time when in fact you could see that they had a peak quite quickly. Amazing. Okay, I think I'll switch to this next case now. I know that this issue will probably come up. So if some of that went by too quick, I know it's recorded. I'm happy. I imagine we'll see some more examples of that on the way. So clinically, this is, thank you very much for giving the clinical context here. This is a 17-year-old individual, concussion 15 months ago due to vehicle rollover, pain and complaints of brain fog. School marks unchanged, but notices that has to work harder. So cognitive fatigue, I imagine. Some problems with sleep and nightmares and possible PTSD. And overarching examination and history was compatible with the concept of a central auditory processing disorder. So in reading that, my mind immediately wonders whether we would see something in the N100, because the N100 tracks from the ear to the primary auditory cortex. So it really is a central auditory processing response. Now, again, looking at the tables, you can see that the N100 latency is at 122 and 140, which is definitely on the slow end. I don't know how far apart these scans are. I would imagine that they might, I think, be actually in the same session. A lot of times, I have some knowledge of how this was done. A lot of times for cognitive fatigue, clinicians will scan first at the beginning and then do a session and then scan later to look at if there's any changes. So my suspicion would be it was done in the same day in the same clinical session. And it looks like Marcus just confirmed said suspicion. So what we're seeing is a delay in the N1 latency. We're seeing replication of the radar plot quite closely. There's really not a lot except that we're going to expect a large N4 amplitude and a relatively large-ish P300 amplitude. And good replication within the session. So let's move to the actual waveforms. Yeah, so there it is. that is an interesting exam for a number of reasons. The first is, again, my eye from sanity check always loves to go to the purple waveform, the standards. And you can see a small N100 in that is also delayed in the second scan at 140 milliseconds. So I believe the AI has done a good job in detecting this. This would also, from a waveform morphology, would be quite atypical. This is not a typical looking morphology and would be definitely indicative of or correlate with the concept of a central auditory processing disorder. Now, the interesting moral of that story is I learned early on in doing this clinically that don't always expect that you necessarily will have delays compounding. Sometimes that can have a knock-on effect for a slower P300 and an N400, but not always and often not. So you don't necessarily assume just because there's a delay in sensory processing that that will have a compounding effect on the other two components. So let's take a look at the other two components and see what we can see. So again, these are coming in at 282 and actually exact on both. And the waveform is very replicated and looks very strong. The size of the waveform at 5 and 7 microvolts is not in a major range of concern. I would sort of flag this as a fairly prototypical looking P300. I don't know that I would say that there's a lot of change between the pre and the post, even in terms of for those who are not quite used to looking at the ellipses yet, the ellipse describes variability. So it's showing larger amplitude variability than latency variability. And we tend to like to see, I always describe it as a football standing on its end like this. So these responses are generally, I would say, fairly within normal range. We can go next to the N400. So this is interesting because we were told also about this individual's age. And this is an interesting case. You can see that it's a very straight baseline, pre-stimulus baseline in both cases. You can see that the P200 is very easily identified, but actually is attenuated in the second case. And the P200, for those who are interested, is actually generally associated with kind of attentional perceptual processing. So there's a larger attentional processing in the P200 preceding the N400. Now, this is a good case of is the first scan a PEMN and the second an N400? And is the first peak in the first scan and actually an N400? I'd be interested for people to jump in on the chats and see, because I know what I think, but I want to see if people will take a stab. The question is, did the AI get this correct or not? Or would you adjust the first scan and then subsequently consider adjusting the second scan to the earlier peak? I won't hold you in too long suspense because time is money. I would not change the scan. This would be AI is correct. Correct. Andrew got it right. Full points to Andrew. I would not adjust the scan. This is absolutely an N400 in both cases. And the latency is very stable. And there's an interesting sort of shift in the disappearance of the PMN in this case. Great case. Thanks, Marcus. Next. Okay, so we got a 54-year-old male, second test well outside of normative range. Additional information. The second scan, there was a clinical noting of a little more distracted, or the client could have. Yeah, quick scan of the table first. It's flagging the P300 amplitude as being low. Yeah, that's pretty much what you see in the radar plot too, is the P300 amplitude. You're expecting that to be a little low. We're also expecting maybe a low N100 amplitude and a high N400 amplitude. So again, these are great visual indicators of what to go look for in the waveforms. So let's go look in the waveforms. All right, this is an excellent case. Clear N100s You can see in the purple standard line a very pronounced N100. The most trials go into this average. So that is telling you that you've got a pretty good physiology, but there is clearly an artifact in this. I know that there are people on this call who know what this artifact is, but go ahead and throw it in the chat, and then I'll explain how I can see it. Anyone? Andrew, Brody, Marcus, Alpha. Yes. So, well, NeuroCatch does in the algorithm does an actually quite a admirable job. This is a shout out to all the engineering and the science behind that was developed over the years. It does a really good job handling artifacts. You don't really have to worry if you get that signal quality check, and you can see in the waveforms that the pre-stimulus baseline is looking good. It generally does artifacts well. However, the alpha frequency overlaps directly with the same frequency band that ERPs are recorded in. Therefore, if we filtered alpha out, we would filter out the ERPs. So what you can see here, the easiest way to see alpha is to look in the deviant tone. And we expect that alpha is sort of anywhere from 7 on the low end to 14 or 15 hertz on the high end. So if you can count anywhere from 7 to 4 to 15 basic peaks in a second, which is the size of the segment, then you have alpha. I, of course, have looked at alpha lots and lots and over the years, and I can see it in the waveform. It's that kind of rhythmic sort of 7 to 15 hertz signal that's sitting in the deviant range. So this will get interesting when we interpret our P300, which we can go to the next scan. So here, this has been peak adjusted because it's turned to blue, and it's selected probably what I would agree with as the right one. Immediately in my mind, I would want to rescan this patient and confirm this in a state where I clinically work to reduce alpha. If they were drowsy or otherwise, I would just want to get another scan at another day. It doesn't have to be the same day or same session, and confirm that that peak is actually has power in the P3 range driving it, in spite of having alpha sitting in the same frequency range. The reason you can typically see that is you can actually see the lower frequency of the 3 peaks getting driven up. And so my suspicion is that is probably the underlying P300, but I would definitely recommend a rescan to confirm. Next. Now, this is interesting because this is an important teaching moment. On the N400, we use much heavier filtering. So alpha, and by the way, both the incongruent or mismatch word and the match word are equal in trials. So now you can't just go look at the congruent to see what's going on because they have the same number of trials going into them. And the alpha tends to show up more as kind of this wild low frequency change when someone has a high degree of alpha in the scan. You can see the pre-stimulus baseline. That is definitely probably, I would definitely probably, that is in my mind strongly indicating alpha in the scan. And then I still see basically a P200. So I'm still suspecting that this was properly peak scored. But again, I would be watching the N400 in a rescan just to double check and verify. Great scan for looking at the effects of alpha. All right, I had mentioned about shrinking to the center is definitely something my clinical eye will look for. You can see that there's some definite sort of regression to the center of the radar plot. We can see that this is being driven by a combination of a very slow N100 and also some changes in the N4 latency and P3 latency. I tend to, in a clinical time, watch latency more so or faster than I watch amplitude. So we're going to jump right into this waveform. We know this is all we know is it's an MTBI case. So let's go see what's going on. All right, so this is definitely delayed. There is no question. You can see in the purple waveform, there's a small peak just preceding that, which suggests that the N100 is delayed towards 200 milliseconds. We do not tend to see delays outside of, let's say, 120 that are not that would not, for me. I like if I would understand normal variance of almost like 110 to kind of all the way down to 75-ish range. So seeing something out in 196 to me is definitely delayed. This is an interesting case because that delay does not appear to necessarily have a major knock-on effect with the P300. So let's go have a look at that. So this is interesting because the AI selected the second peak. And often, as we all know in this community, we're looking at, is it a P3A or a P3B? This is a case where you might consider looking at that earlier peak as a P3A because it we tend to default to the P3A. If you do that, of course, you would adjust the amplitude down as well. I This is a very, again, when in doubt, when it's ambiguous, I would go to a rescan because the P3A and P3B can vary a lot in patients. And so I would kind of want to see what a rescan would show. I would probably err on the side of not correcting the AI at this particular case, just because I've seen that the N100 is significantly delayed. But that's an interesting one. And I noticed, hang on, I'm just going to read this comment. Scan of a 50, this was scan 56 of the same person conducted late after an exhausting conference and travel. Okay. Yeah, so if we have 56 scans of this individual, I would check as to, if these delays relate to exhausting conference and travel and are shifting, because that would mean that auditory processing and P300 were shifting as a function of that reason.
I think he's referring to scan 3. And we can pull up that one when we're finished with this.
Oh, okay. Okay, perfect. Thanks. I lost track. Okay, so let's go to the next one. So in this case, again, hopefully your eye notices a couple of things. One is that there is a smaller and reduced P200, which then actually is showing a later N400. It is legitimately AI tagged there. It is not a very, from a waveform physiology, that is not what I would call a typical N400 waveform. And so that would lead me to, again, not change the AI and flag this person at 592 and monitor this waveform for more normalization. If I was doing treatment and rehab, for example, in terms of an MTBI case, I would want to see this separation come and sort of normalize more to a prototypical N400 pattern. Yeah.
Okay. All right, so that's the last one we have on the slideshow here. I'm going to go ahead and share a PDF of this other scan that Andrew referred to. So give me just a moment. So this one would be a third scan on case study 3 that we looked at. So just one second. Can everyone see that okay? All right, Ryan, I'll give you the floor back.
All right. This is someone who scanned themselves 56 times. There's only one person on the planet who's done that, that I know of anyway. What are we looking at? Third scan in a row on a different system, cross-checking the new system with new EPIO. N400 looks off in the first system scan 1, but closer in scan 2. Okay, so I don't really understand that, but let's just read the scan and see what we get. So the table's showing low P300 amplitude. Everything else is in range. Let's go to the radar plot. Well, there's the low P300 amplitude. We can see that there was a peak select used as well. So we'll take a look. Everything seems to be in normal range. So we'll go to the waveforms. Good N100, standard, smaller than deviant, 90 milliseconds. Nothing to comment there, except you can already tell that we're not seeing a typical P300. So let's go to see what the algorithm did. Yep, that's what I would have done. That was peak selected and changed. So that was the amplitude and the latency, and I would have flagged that as the P300 too. It's interesting that it's low, but with more scans on this individual, we could compare that. And then we can go to the N400. That's a nice looking N400. Um, Actually, that's a really good demonstration of an N400 because you can see the clear P200. You can see it diving into kind of the N400 at 420, and then you can see the power of the PMN actually driving the peak down a little ahead of time, but not all the way to full semantic closure of a mismatching word. The other thing you can tell here is that this person is identifying matching and mismatching words nearly in the same kind of process. So matching words have the same salience to them and as mismatching. And sometimes you will see that in cases where even though you tell somebody to listen for the first word and identify if the second word mismatches, you will see individuals who are sort of default to identifying the matching word, and you can see that in the congruent word. You can see that sometimes the peak will be a little ahead rather than behind. Yep, and Andrew's given us average N100s of 91 milliseconds, 242 milliseconds, and 383. So he's off of his average there. So he's going to have to do some red light therapy.
All right. We'll see if we have time for one more, but before we do that, I want to share with all of you as a thank you for being here. We do have a new software update coming out, I believe early next year, coming soon. And with that, we're going to have a new look to the NeuroCatch report. So I do have an example that I can share. So just to kind of talk through this a little bit. So the first page of this report is going to be what we hope is a really helpful summary page if you're trying to explain this with research participants, clients, patients, whoever it might be. So the goal here was to take it, if values for latency or amplitude were above, below, or within reference range, to try to translate that into more layman's terms and more words than numbers. So I see this as being a good take home, just so someone doesn't have to look at waveforms in a radar plot if they want to take it home and show their partner or their family or anything like that. Embedded in this report too is a lot of different, we've taken out the glossary and the appendix at the end of the report, and we hope that a lot of the definitions that were below the report are now embedded within it and a little easier to follow. We also have a new look to the radar plot. So the green is gone. We've gone with blue now. So on the top, we have a little orientation to what we're looking at and what we mean by brain vital signs, along with definitions again of our ERPs. And then finally, we're highlighting a little more clearly values that are outside of reference range on the radar plot. If they are out above or below that reference range, they'll be highlighted with an orange diamond on a single scan report. That way, those that are just kind of on the edge, you can tell if they're within or not within range very easily and very quickly. This is our new data summary table. So we've taken those bell curves and kind of squished them down into being a little different here. So we have our reference ranges, our values, which are now out of range, are also going to be highlighted in an orange box, like you can see for the N100 amplitude. And then peak select is blue and always will be blue. And then by popular demand, our waveforms for the tones and our waveforms for the word pairs are finally where they should be. So our N100 and P300 are now displayed on the same waveform. Peak select is going to work the same way. And now if someone has the PAMR detected, then N100 just won't be listed, but the P300 will still be available on that waveform. And then finally, the variability assessment, instead of those big box plots on every page, we've now condensed that a little bit to be smaller. And now the report is 4 pages, so I hope that saves you some paper and ink, rather than the 9 pages. So again, this software update also includes a different multi-scan report, so maybe we'll take a look at that next month. But this will be available hopefully in the new year. We're hoping.
I want to give a quick shout out to Claire's amazing leadership. Claire absolutely drove the revision of this report and did a phenomenal job in coming up with getting all the input from all the users and all the clinical experts and really taking the report into the next generation in this beautiful format. So congratulations to Claire and thank you.
Yeah, and definitely once it starts to come out and any thoughts that you have today, definitely send them in. Um, Always open to suggestions and making it better for you because it's not for me, it's for you. I'm just training you on it. So let me go back to our slideshow here and we can open up the floor if anyone has any questions. You can mention them in the chat or come off mute and ask any questions. And follow us on social media for more events and news like this. Jaden has a question.
Hi. So thank you for that amazing presentation. But I have a few questions. I know we are kind of tight on time, so I will try to condense it as much as possible. Now, my clinic is quite new to NeuroCatch, and I would like to know about the other applications for NeuroCatch outside of brain injuries and stuff like that. So what I have in mind, and a question that I've been asked to ask you guys, in terms of sport and in the corporate sector, can it be applied to detect fatigue or to boost productivity in that aspect of the brain just being fatigued, if that makes sense?
Mm. Yes, I think there's some great individuals on the line who could probably answer this, Jaden, and thanks for the question. NeuroCatch, first and foremost, is intended to be a tool. Its indication in is for aid in diagnosis or for cognitive assessment in the United States. So it's a tool in a clinician's toolbox. And what's unique about it is that it looks at an individual's cognitive ERP profile or brain vital sign profile and compares, does a good job of identifying those peaks, and where needed, you can use peak select to update the record. But it basically overlays that on the normative record and then allows you to look at that relative to norm and relative to kind of the metrics we just went through. And the reason I started that is cognitive assessment and cognitive evaluation apply to a number of different domains. So yes, for sure, a clinician may choose to look at an individual if they have questions about a concussion or a brain injury as to their cognitive function, but they may choose to look at them for a number of indications that are of clinical interest to the clinician. So for example, we do have clinicians, one case that was reviewed here where I think that the clinician was looking at cognitive fatigue by using NeuroCatch at the beginning and end of a session to see if there were any differences in that. And there are applications that where if you're looking at an objective measure of cognitive function, then you can use them in applications like you mentioned. But the key part is you're not using NeuroCatch to diagnose a disease. We were told early on never to sort of take away clinical judgment, but to put a good tool in your toolbox that allowed you to use NeuroCatch to look at an individual's cognitive function and make a comparison relative to normative function ranges. So the application can be quite wide because that's completely within your clinical discretion. Is that helpful? Jaden?
Yeah. You're on mute, Jaden.
Oh, sorry about that. Yes, it did. I just have one more question that it's a bit more specific that would clear up a few things on my side. So to get more specific, in terms of sport, let's say we're playing soccer, could this help a coach be able to rotate a team? For instance, he has a bench with substitutes, and the substitute shows a better cognitive response than someone who has been playing, let's say, 5 games. would um their response on the field and their cognitive response be shown on in the results to help the coach make a team-based decision?
So typically, the indication for use would be for a clinical professional. We do have clinical professionals in sports facilities, and we have looked at performance-related questions. Probably the critically important aspect within that frame of reference is NeuroCatch is strong at measuring within an individual, so changes within an individual. So any individual could scan as long as they were sort of scanning within the usage of NeuroCatch, the ability to look at an individual's change and make a determination. For example, I'll use a really basic concrete example. Within physical therapy and performance teams in sports, they can scan individuals and look at the effects of travel and jet lag schedule and decide if that's had an objective impact on their cognitive function, right? So within the realms of what is specified for our regulatory guidelines, those are applications that absolutely could be used for, yes.
Okay, thank you very much.
Yeah, thanks for your question, Jaden. If anyone else has any questions, we are out of time. So feel free to email us at the support inbox and we can always pass them along to Ryan if they're specific for him. But as another thank you for all of you joining, you were promised that one of you who's in attendance today would be entered and drawn into a private report reading session with Dr. Darcy. So I'll stop sharing my screen and hand it over to Shannon and the Wheel of Wonder.
Oh my goodness. Okay, hang on. Let me see if I can pull it up here. Ooh. Okay, can you guys see it?
Oh, it's got music.
Oh, that's a whole team over at, I have to look it up. Hold on a second. Team support. I'll get back to you. Because it wasn't an actual name, but we had a whole group from Claire, do you know? I'll have to get back to you guys.
Yeah, you have your whole screen shared, Shannon.
Oh, yes, I do. Okay, I'll get back to you guys with the winner, but that's a good one because we got a whole team that's going to be joining on with Ryan. So very exciting.
Great. And
I'm
keep an
looking
eye
forward
out.
to it.
Yeah, keep an eye out for your emails. We'll reach out to team support and schedule that. And then for the rest of you, we went a few minutes over time, so thank you for staying with us. And keep an eye on your email for next month.
Sweet. Thank you so much for everyone's time.
Thanks, everyone.
Bye.
Bye, everyone. Thank you.